So the TOPGEAR trial was a very large global trial, randomised phase 3 trial that looked at optimum treatments for resectable gastric cancer. So this is a trial that's recruited almost 600 patients across 15 countries and 3 continents. And it randomised patients to what is the standard of care, which is perioperative chemotherapy, or the alternative treatment, which was perioperative chemotherapy with the addition of preoperative chemoradiation as well. So this has been a burning question in gastroesophageal cancer treatment for the last 20 years, and the trial attempted to find a definitive answer for that. So in the first instance, we were looking to see whether the addition of radiation would improve the pathological outcomes. In other words, did it shrink the tumours down more so than chemotherapy alone? And then did this translate to better survival for these patients? So the follow-up has been over 5 years now, and what we found was that the addition of radiotherapy did in fact improve the pathological outcomes. So there was a doubling of the pathological response rate from 8% with chemotherapy alone to 17%. However, after 5 years of follow-up, this did not translate into an improvement in overall or progression-free survival. So these results are very informative because it will potentially change clinical practice. There are centres in parts of the world which use preoperative radiotherapy as standard treatment for gastric cancer. And the other area is in gastroesophageal junction cancers, where 1/3 of the patients on the TOPGEAR study had these types of tumours. And the standard treatment for those tumours is in fact preoperative chemoradiotherapy. So the finding of no additional benefit with radiation will also impact on these cancers as well. So the survival, progression-free and overall survivals were the same. It was the 5-year overall survival was about 45 months in both arms. So the addition of radiation did not improve on the survival. And we don't really know why that was, but a lot of these patients relapse with distant metastatic disease, and radiation is not really going to help that. So at the moment we have very effective perioperative treatments, and that will remain the standard of care. So we know that the standard curative treatment of patients with gastric cancer is surgery. But with high-risk gastric cancers, there have been trials that have shown that the addition of perioperative chemotherapy in addition to surgery improves their overall survival rates. And that's why it's become the standard of care. Radiation has been used as well, but previously in the post-operative setting where we know patients don't really tolerate the treatment as well because they're so deconditioned after surgery. And that was the rationale for using preoperative radiation in the TOPGEAR trial, where we know patients are much fitter and they will complete the treatment. And that was shown in the results because over 90% of the patients completed the preoperative chemoradiotherapy. I guess the question is, what is the role of radiotherapy now in patients with gastroesophageal cancer? At the moment, we would say that it's not recommended in patients who have resectable gastric cancers, but because of the demonstration of very high pathological complete response rates, there would be the potential to use radiation as part of an organ sparing approach where, if we got complete responses, we could avoid surgery in some patients. So that would be an area of investigation.